Well, thank you very much to Olympia and the organisers for inviting me. I'm going to slightly change tack. In fact, I'm probably going to change tack a lot, in that I'm going to give a talk that's very focused on kind of one issue. And the issue that I'm going to talk about is the evidence of responses to pension reforms by senior skilled labour. And this is joint with some folk at IFS, George Stoy and Max Warner. So the kind of question that I'm going to be focusing on here is sustainability concerns have led, as James has said, and those in this room know well, to a move towards pension reforms across the world that have basically been about scrapping generous defined benefit schemes. So an example, for example, is Poland, that moved all its schemes from a defined benefit, all its public sector workers, or in fact all its workers, from a defined benefit scheme to a defined contribution scheme. These reforms are partly because of the different trajectory that different pension schemes give. These reforms are also intended to increase labour supply, particularly at younger ages. But the responsiveness of younger individuals to pension reforms is pretty much an open question, in the sense that almost all research has actually focused on the point at which point people retire rather than before their retirement. And as James said, past research has suggested that individuals are not fully aware of their pension details, over-discount the future, have difficulty processing financial information. And as I said, most research has focused on individuals at near retirement. So what we wanted to do in this paper, partly because of my own interests in labour supply in the public sector, and particularly labour supply in healthcare, is study the impact of a major public sector reform in the UK, which essentially replaced a career average, a final salary scheme in which individuals' pension was based on the last 3 years of their working life before retirement, to a career average defined benefit scheme. So this isn't a particularly radical change in the sense of moving from a defined benefit to a defined contribution scheme, but it's a switch within a defined benefit pension scheme. This essentially provides at a kind of macro level a kind of fall in the generosity of the pension scheme, but it also alters the link between pension wealth and labour supply at different points in the life cycle. I'm going to focus here on a tightly defined, highly skilled set of public sector workers, which are essentially NHS doctors. And the reason is that there's, in systems where the public sector employs a lot of people, and secondly employs a lot of skilled people, there's been a general concern that changing the pension schemes is going to lead to a decrease in labour supply for highly skilled individuals like judges, doctors, senior civil servants, who previously were kept working because of the fact that they would receive their pensions based on the last 3 years of their life. So that's what I'm going to look at. Why this is kind of interest is this was a reform that happened across the public sector. As James said, reforms in the UK tend to be announced kind of out of the blue. This wasn't announced out of the blue, but it was announced that all public sector workers would be subject to this reform that changed from a generous defined benefit scheme to a less generous defined benefit scheme. The group that we want to look at, and we can look at with this scheme, is a group who are sufficiently far away from retirement to be able to alter their labour supply. They also have some outside options. They can work flexibly for their employer, which is the NHS, and they are maybe more financially literate rather than financially literate than other educated workers. So they're a kind of interesting group to study because, in a sense, they're at kind of one end of the distribution. They should know more, they have more options. And the individuals that we examine do have the opportunities, therefore, to change their labour supply in response to the reforms. And the reason that kind of I'm interested in this group is that their labour supply matters for healthcare provision. This is a group of doctors who provide about half the doctor labour force in the NHS, and are also a group of doctors who essentially manage large teams and teach younger doctors. So, as a kind of preview of kind of where I'm going, as I say, this is more of a kind of academic paper than a sort of overview paper. The impact of these reforms is theoretically ambiguous because there's both a wealth effect and an income effect that's going on here. So there's a substitution effect and a wealth effect. So what we're going to do in this, and this is the sort of backdrop to this, is exploit the staggered rollout of the reform to estimate labour supply impacts. And then we want to use those to derive labour supply and wealth elasticities. As a kind of side issue on this, there are actually not very good estimates of labour supply for doctors in the UK. They're all a bit old, and many of them aren't really kind of causal. So this was kind of a side aim that we were interested in. And kind of what we found, so basically these reforms were accompanied by huge howls of protest ex post by the doctors' union that argued that such reforms in terms of decreasing generosity would lead to massive changes in labour supply. And indeed, we do see that doctors are coming out of the NHS and working less. And the British Medical Association, the Doctors' Union, has attributed this to these reforms. In fact, that's incorrect. These reforms increased people's labour supply. Not very much, but people were, after 4 years, they were 3% less likely to leave. And after 6 years, they were 8% less likely to leave towards the end of their working life from the NHS. We find larger responses for people who have less outside options, so that's quite nice. That does fit with what economic theory would kind of tell you, that if you have more outside options, you might do something else. And we also find a labour supply elasticity with respect to pension wealth of about minus 0.05, which is pretty much in line with the rest of the literature. A rather lower labour supply elasticity for these senior doctors than some of the other labour supply elasticities for doctors. We find about 4%, some of them find up to about 10%. And so essentially we conclude that doctors are responsive to pension changes, that labour supply changes that change them from pensions, and not necessarily in the way that the doctors' union predicted. I have to say that I'm not sure that the government predicted anything about how these policies would affect their kind of more senior labour force individuals. They certainly didn't really predict what would happen in universities that have a similar kind of scheme. So I think kind of thinking about this is, much narrower than the talks we've been doing, but the kind of contribution relative to the previous literature is that I say most papers have focused on what happens to people near retirement. We're going to focus on people between the age of 48 and about 58. So these people are quite far from retirement in some cases. There are kind of a couple of similar papers that have focused on similar reforms. The French et al. Paper is for Poland that, as I say, moved from a defined benefit scheme completely to a defined contribution scheme. And I think we're focusing on a group of people who are very important for delivering a particular service that accounts for about 10% of government spending. On terms of the doctor labour supply literature, as I said, there's relatively little on doctor labour supply estimates for the UK. There's just a couple of papers. There's a little bit for Norway and Australia, but in fact, all healthcare systems differ. There's some for the US where incentives are very different. And we provide evidence, I think, on the importance of delayed remuneration and pensions as distinct from current remuneration. So the kind of background to this as to kind of why this is kind of an interesting group to kind of study is we account for we're looking the senior consultants that we're looking at, the senior doctors who are called consultants in the UK setting, account for about just over 40%, 2 in 5 of the doctor labour force, and about 8% of the totally qualified clinical labour force, which includes midwives, nurses, physiotherapists, other things. Our folk are like many European systems that run like the Spanish system or the Italian system or the Norwegian system. These guys are public sector employees, they're salaried, and in our setting they're paid on national wage scales. So you're paid exactly the same as a doctor if you work in Scunthorpe to if you work in Skegness. Skegness and Scunthorpe are 2 separate towns in the UK. You get additional pay for additional responsibilities, shifts and performance. There's a little bit of performance-related pay that's not actually related to your current employer, but your performance outside your current employer. However, doctors in our system, like in other systems, like in Australia, like in Italy, like in Spain, can work, and Norway, can work in the private sector either alongside the NHS or they can come out and work just in the private sector. And there's considerable variation in the availability of this private work geographically. So most of it's in areas where people are richer, as you'd expect, because they have to pay for private insurance on top of the tax contributions they have to make to the NHS. So this is supplementary private insurance. You can't opt out of your NHS payments. So the availability of private work happens in places where people are richer on the demand side. So the reform, as I say, was introduced in 2015, but announced in 2012. So in 2015, there was this move from the final salary scheme, which was based on your last 3 years of employment, to a career average. So it obviously changes the incentives across the lifestyle. So it gives greater return to work more than 3 years from retirement. And it gives less incentive to drop out of the scheme towards the end of your career. But the other thing it did was it changed the later retirement age. So there's a big change in retirement age from 60 to 67, which reduces the total value of your pension by quite a lot. That's 7 years. There's a small issue that is a later early retirement date, but not many people retired at 54 or even 50, but it mechanically delays retirement. So the kind of slightly curious thing was those moved on to the new scheme were still entitled to the previous pension pot that they had under the old scheme. So in some ways, these changes were quite marginal. So you might expect nobody to do anything to them. And the other nice thing about this is a kind of trying to kind of drill down and really look at a reform and try and get something causal, is there are no changes to either employee or employer contributions that kind of come along with this. So obviously, there are several components to the reform with different effects that might affect labour supply. The first is the relationship between current pay and pension value, the move to a career average. For those who are more than 3 years away from retirement, changes the return to additional pay, so has a substitution and an income effect, so obviously ambiguous. There's a change in the pension value. Delayed retirement age decreases the value of the pension for senior docs and is basically a negative wealth shock. For those with no outside option, this in a sense increases the incentives to supply labour to the NHS. But for those with an outside option, so an outside option to essentially either work in the private sector or do something different, it does provide an incentive to work outside the NHS. So the effect is kind of ambiguous for those guys. The minimum retirement age, as I say, simply mechanically increases labour supply. So the impact of the reform is ambiguous, and we have a little kind of toy model in the back of the paper to show this, and depends on outside options. So what we're going to do, and I'm not going to spend masses of time kind of going into the weeds on this, but essentially one of the nice things about this scheme is because everybody thought that it might not be a good idea to introduce it in a big bang way, it was rolled out. This scheme was rolled out. It was announced in 2012 that it would come into being in April 2015. Those less than 10 years from retirement in 2012 were never moved at all. They simply remained on their old scheme. And then everybody else, those that were between 10 years and 13 years from the original retirement age at 60, were moved over time. So essentially one birth cohort was moved every 2 months. So depending on what your birth date was, you were moved in a 2-month staggered period. So that means that essentially you can compare somebody 2 months before with 2 months afterwards in terms of their labour supply, and you can kind of stack all these up. And that's exactly kind of what we do. So we're going to essentially kind of compare within individuals as they kind of move over time. We're going to use a data set which is actually a very nice data set, which is essentially the payroll data set for the whole of the NHS. This is a pretty handy data set. It tells you what a payroll data set would tell you, essentially what your employer knows about you. We're going to define a cohort of senior docs who we can look at and who can... So as I say, our aim here is really quite a very narrow aim to actually look at how this affected those people that were affected by this pension change in older life. So we're going to exploit this staggered treatment, which means that we define a cohort of docs who were born between 1962 and 1969. They're about 10% of the NHS doctor labour force. And given this kind of narrow cohort, we have we then kind of take a slice of people who were working in the NHS in 2012, and we follow them over the next 7 years until 2019, and we ask what they do with response to this scheme. So we kind of have 3 years pre-reform for everybody, and then we have periods pre-reform depending on when your birthday was. So our consultants are about a mean age of 48. So that's what I meant about this is an ability to look at people relatively far from retirement in terms of their response to a change in their pension scheme. About a third of them are female. Almost all of them are working, more or less all of them are working full-time for the NHS. In 2014, their pay is about 120,000. And almost all of them were members of the NHS pension scheme. So we essentially, and as I say, I'm not going to spend it, we essentially, for those who want to know about this, we use a staggered diff in diff scheme because of people being moved over time, depending on when their birthday is. And we control for group and time fixed effects, and we use a kind of estimator that's an imputation estimator. That's a recent imputation estimator to deal with this problem. What we need to do is to identify this is assume that other factors determining doctor labour supply condition on our controls are uncorrelated with treatment timing. We do quite a lot to kind of net that out. As I say, the staggered nature of this and the fact that we never look at the never treated allow us to deal with things like common anticipation effects. So I think we also do various tests for the fact that we do or do not have identification, because our real aim here is really to kind of get at causality. So in terms of our results, we're going to look at several things. First of all, we're going to look at total labour supply to the NHS of these folk. Secondly, we're going to look at an extensive margin, whether you were working for the NHS or not. And then we're going to work out how much you work, condition on working. So remember that this is a group who can change their hours pretty much at will. This is a group with a lot of flexibility around their hours. And then finally, we're going to examine the effect on pension scheme membership. But that's not an aim. So basically, this is the kind of big picture that we get. So this is the figure of total labour supply. And the bottom of the graph is the months before is the month since the switch. So the minus 36 is 3 years for an individual before the switch, and then we follow them out after the months after the switch. essentially you see no pre-trend. So essentially there's not, which is quite interesting, within this cohort who are going to be affected, there's not much, there's no anticipation effect, which is good for our design, but also does say something about, how often people change their views about things. So there's no pre-trend, so there's no different anticipation effect between those moved earlier and those moved later. And there's a 7-year difference in maximum between those moved earlier and those moved later. So as I say, 4 years after being moved, senior docs work about 3% more for the NHS, rising to about 8% more after 6 years. And that's about, because most of them were working pretty much full time, that's about a 3.5 to a 8.5 increase for the NHS. So that's not bad. You've got your senior docs working more for the NHS. That's mostly all on the extensive margins. So essentially what's happening here is doctors, instead of coming out of the NHS, stay within the NHS, despite the fact that medical unions are saying we're going to be seeing people leaving in their droves. So mostly, actually, you interpret this as reduced leaving. They would have left under the old scheme, but they no longer leave. It's not mechanical from the increase in retirement age, because almost all of these folk are under the previous retirement age of 60. There's no significant change in the intensive margin. And essentially, there's some very funny behavior that goes around the pension scheme. So what people do is, the minute they're affected, they remove themselves from the pension scheme. However, 12 months later, they put themselves back into the pension scheme. Now remember, these are pretty financially literate individuals. These are senior doctors, most of whom have had to have if not a math degree, a science degree, a science qualification, and a pretty much science-focused degree. But they all kind of remove themselves from the pension scheme and then immediately go back in again, and indeed increase participation in the pension scheme. So essentially, again, this is fewer doctors are leaving the pension scheme than before, which is a good thing because you want them to be contributing to the pension scheme. So the labour supply, as I say, is there's an increase in labour supply. It's driven by an increase on the extensive margin. And these results, we go through a whole pile of things in this paper. They're pretty robust to kind of including the never treated, including hospital fixed effects. We get similar results with OLS, even though we play around with fancy estimators, and they're kind of robust to cohorts. So then our kind of interest is is there heterogeneity? We do find, which is nice actually, and kind of fits with what you predict from economics, that the labour supply responses are larger for doctors who have fewer outside options. So when you do have outside options, essentially, you might continue to leave at the same rate as you did before. But if you don't have those outside options, essentially, you keep working for the NHS when you otherwise would not have done so. The interesting other thing we find in the kind of labour supply literature is there are very similar results for men and women. Now, this is a specific group, but about a third of our sample are female. These are hospital doctors. We find that male and female hospital senior doctors behave very similarly in terms of their labour supply. 10 minutes, yeah, easily. So we end up, as I say, having ended up here, we're interested in what this actually means for what was the financial impact of the scheme and what did it do to labour, our estimate. Can we derive labour supply elasticities out of this? So we can derive labour supply elasticities out of this, out of an assumption that we have to make, which is that females and males respond similarly to the scheme, even though the scheme affected them differently. And that's essentially the trick we use to get out labour supply elasticities. So just to kind of show you what the reform has, we need to know the financial impact. So the reform has two major financial impacts: a reduction in pension wealth, primarily driven by the 7-year difference in retirement age, but an increase in pension returns if you're more than 3 years away from retirement because of what the scheme did. So we can use our estimates to get labour supply elasticities out of this. And as I say, we compare male and female docs because there are different financial impacts by gender due to the fact that women live for longer and they have different earnings profiles, but we find the same labour supply response. So we can separate out the effect of the two channels under the assumption that labour supply, the two financial effects affect labour supply in an additively separable way. What we get, interestingly, is that obviously the big impact of this scheme, as you can see in the table in the middle, is the wealth effect. This scheme has a big wealth effect for these individuals, around minus 40% in terms of wealth, but it has about a 20% increase in incentive effect. So the incentive effect is that for each additional pound earned, this scheme, for those who are at least 3 years from retirement, they get an extra, up to an extra 20 pence in their pensions. So these are quite big changes. So it's interesting that these are quite big changes, but we don't get very big responses, labour supply responses. So our estimated elasticities end up, as I say, with about a 5% elasticity on wealth and an incentive effect that's kind of smaller. Both the elasticities are in the expected direction, but kind of smaller than for when you estimate these things for the average population who are working. And it may be that these people are less responsive to delayed remuneration than they are to current wage changes. So I think I won't spend, I just kind of conclude that actually this was a much more remember that this is a government scheme, so it comes out of taxation. So the introduction of this much more affordable pension scheme actually increased labour supply of senior docs in the NHS. It was driven by an increase on the extensive margin, so people stayed working for the NHS when they would have otherwise come out of the NHS. And that's a result, really, of the decrease in pension wealth and the increase in current labour supply elasticities, incentives. It belongs to both. And it increased the number of senior docs by about 5%, which is not negligible given that there's been these huge arguments about retirement of senior docs following COVID, following too much overwork, and following underfunding of the NHS, which is a kind of pretty much constant refrain that's going on. Has larger impacts for those with fewer outside options. And I think then the flip side of this says is that obviously we can't say anything about what these kind of reforms do to the people who are either thinking of entering these professions or are younger, because we can't actually identify anything causally for them at all. But on the other hand, I think that the sort of takeaway that I take from this is that pension reforms don't necessarily, despite what the union reps might say for this, reduce the labour supply of highly skilled individuals who are in a career that they have some outside options, but not necessarily because of their age. As I say, their average age is about 48. Because of their age, aren't necessarily going to change what they actually do that much. Okay, and I want to say thank you at that point.
Now, first of all, very interesting, and fun enough, I was talking yesterday about the reform of the pension of doctors in Italy, and so what you are saying is very interesting. how do you measure the outside options? Because the labor market for doctors is particular, and also the way seniority in the case of a doctor is something that really is very much related to skill acquisition. I mean, so I wonder how this is done, especially because it seems to me that you work on payroll data from the NHS, so you don't know much about what happened also to these people leaving the NHS.
So the way we measure the outside options is in a kind of crude way. I would love for HMRC, which is our tax authorities, to give me the tax data on these doctors, but they won't. So given that, I don't actually know what they do actually earn. So we use another data set where we use, from this, we use the share of doctors who are working outside the NHS in each hospital as a measure of outside options. Because outside options tend to be geographically, we could use a number of things. We could use the distribution of private facilities, private healthcare facilities, which is a small sector across the UK. What we actually use here is each hospital has a number of doctors who are working outside the NHS. We have a data set on that. We match them to the hospital, and we simply divide in this data set above and below the median. But we could divide more finely. So we know how many doctors in each hospital in 2020 actually are working outside the NHS in the private sector as doctors, because most of these folk will be working as doctors, and that's how we define it.
So it would be an effect related to the hospital?
Well, it is but this is robust to hospital fixed effects because there are variations across specialties, yes. So it isn't just geographic. The point from that is it's not just geographically driven.
Yeah, indeed, super interesting results. Thank you. Related to Tito's question, I mean, to what extent one could say that the results of the reforms are a change in the composition of the total labor supply, NHS plus non-NHS, and to what extent is an increase in the overall labor supply? Do we know enough about the non-NHS to look into this?
Yeah, that's a really good point, and we haven't thought about that, partly because the non-NHS is a very small part of healthcare provision in the UK. It's very concentrated in certain operations for which there are long NHS waiting lists. Not surprisingly, this is on top. People don't have private insurance for things they could get in the NHS. They have private insurance for things they couldn't get in the or have to wait for in the NHS. So we've never asked what it does to labour supply outside the NHS, because that's quite a small part of the picture. But we actually could use our data that we have on private work by NHS consultants that we can match to these folk to answer that question. The thing that we want to go on to do, which we haven't yet, is actually look at whether this affected the care of individuals within the NHS. Because in a sense, you don't really, you do care about labour supply, but in this game, what you really care about is what impact that labour supply has on individuals' health. We find when we look at that, which we have to look at that at hospital level because we're matching another data set in on hospital outcomes. We do find that waiting list declined, but not significantly. We don't find any change in emergency care. So it appears that most of this happens in terms of decreased waiting times. We don't find any better outcomes in terms of death, but you might not expect a 3% increase in senior doctor labour supply to do that. And of course, there are other things possibly happening to labour supply of younger folk that we don't know about. So we can't associate these individuals. We can't match the payroll data to their activity data. We can only match at hospital level. So I think we find some effect, some positive effects, but nothing very big. And I think that actually fits with something, I mean, that's partly because we're looking at very short-run changes in order to get at these, I mean, we can look at the months post, but I actually think one of the things about NHS production, as someone who's spent a lot of her time looking at healthcare production, is policies don't usually have a very quick impact. Tends to take kind of a few years for them to roll through, partly because it's a very large labour force and partly because it's a complicated labour force. So we get something positive, but nothing very big. It might be that in 4 or 5 years' time, we see a much bigger positive effect. In fact, what we won't, you know, in a sense, what we'll find is instead of a deterioration, we'll find a kind of, it hasn't changed, but yeah.
Any more questions?
Very interesting, thank you. I wonder, one of the things people talked about with the DB schemes where they were quite heavily dependent on final salary was that the actual trajectory of pay was manipulated either by the unions or the employers to either reduce or in some case increase the dependency of the pension. But obviously that's one of the reasons you go to average career earnings, because it's sort of some sense fairer. Is it possible to actually look at whether or not some of those kind of salary effects have changed as a result of this reform?
It's definitely possible to look at that. We'd not thought about looking at whether people change their trajectory of what they do. I mean, obviously within universities, everyone used to kind of become head of department, because head of an academic department gave you extra being chair of an academic department gave you extra salary. So everyone would do that in their last 3 years of employment, probably to the detriment of any policy, you know, any decent, you know, kind of decision-making at all happening. So we could look at that very easily because we have these trajectories of pay over time, but we just never did. Nice point. And it does matter because obviously these guys are doing the same thing. They need to be managing their departments. And a lot of them do quite a lot of administrative work and take on administrative work towards the end of their careers.
I wonder what the response of the BMA was to your research. Have you presented in front of any doctors?
I'm trying to be nice to the BMA because I want some of their data. So for the moment, we're not saying anything to the BMA. But they're not going to like this. I don't think there's that. I think that's pretty much, you know, an easy question. They've been arguing very strongly that these pension... I mean, there are other pension reforms going on as well, which luckily our design means that they're common to all these folk. But the BMA have been arguing very strongly that these pension reforms are a disaster for the NHS. At least this particular one is not. And it is a big change to go from age 60 to 67. I mean, that's mainly what's, you know, 40% of the effect comes from that. Sorry, about 75% of the effect comes from that.